Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner. Hi everyone, welcome to Melanoma Matters. I'm James Larkin.
And I'm Sapna Patel.
So today we're going to be talking a little bit about the SWOG adjuvant study, but before we do that, Sapna, I'm going to ask you a few quickfire questions. I think the first one is tea or coffee?
Both, not at the same time, different times of day. I like, if my drink is going to get cold, I prefer tea because I can drink cold tea easier than cold coffee. But I'm usually coffee in the morning. Yeah. Unless I'm in Sri Lanka, then I want tea in the morning.
Oh, really? Okay. So then in a departure from the script, cat or dog?
Oh, I've had both. We grew up with a cat, but as an adult, I had a beloved dog for 16 years. So I think I gravitate more towards dog.
Yeah. And then final question, last workout, and you have to be honest about this, okay?
To be honest, it was yesterday. I joined a rec center, so I went and checked it out. So I did weights. I did just a bunch of weightlifting. I did squats, deadlifts, bench press, pull-ups, push-ups. Yeah, that was it. No cardio.
Yeah, well, good. The importance of strength training, which has just actually reminded me. Can you see that or not?
Shut up and squat. No excuses.
I think my team actually gave that to me because I'm just a total bore on the subject of strength training. But I mean, this isn't the podcast to talk about strength training because there's so many other good ones out there, including obviously Peter Attias. Right. Okay. So SWOG adjuvant study. You were one of the lead authors in the publication, so congratulations. Fantastic, important study. Maybe not getting as much attention as it deserves, though. So if that's right, why do you think that is? And maybe you could just take us through a study a little bit as well.
Yeah. So you're referring to the SWOG S1404 study, which remains the largest adjuvant anti-PD-1 study completed in melanoma, 1,303 patients, randomized 1-to-1 to pembrolizumab in the adjuvant stage, resected stage 3A and 2A to 4 melanoma. Versus investigators' choice. And they had a choice here of interferon alpha 2B or ipilimumab. And when the study started, ipilimumab did not have an adjuvant approval in the US and globally. And so it was versus interferon. But as the study evolved, we gained approval, I think it was 2015 or later. And so we incorporated ipilimumab. By the end of the study, 2/3 of the control arm had received ipilimumab. The study also took place in Canada and through Clinical Trials Ireland. So this study was started, let's see, the number is S1404. So the nomenclature means in 2014, it was developed and approved by executive committee. And usually these SWOG studies will take about 400 to 500 days to open. So it likely opened sometime in 2015. And this was before the origin of, or the opening of Checkmate 238. So once our study S1404 was underway, Checkmate 238 was pretty easily developed. Oh, we can do a study of adjuvant nivolumab versus ipilimumab. And that was an industry-sponsored study. So without all the sort of red tape of a government-sponsored study like the SWOG study is. It's part of the US's National Clinical Trials Network, and so it has to go through approvals. And it was a regulatory study, which meant we had to have multiple conversations with the FDA. So that can slow things down. Industry is a lot swifter, faster. They wrote the study, opened, executed, put their first patient on after the SWOG study was opened, and closed enrollment faster than the SWOG study did. So before we knew it, congratulations to Jeff Weber and everyone. They were able to report Checkmate 238. I think that was a plenary at ESMO several years ago, and then FDA approval. By the time S14 reported out, I'll tell you, we hit our analysis. It was during the pandemic. which is years after 238. So this was March of 2020, I believe, reported at ASCO 2020, and then published in 2021. You've kind of lost steam for this question, right? Adjuvant PD-1 versus active control, you know the answer. And so I think this study sort of gets buried, but maybe for other reasons, I can tell you there are probably important reasons to pay attention to it.
Yeah, so maybe top line results. I mean, we've talked a little bit about side effects, and the other thing I'm sort of slightly interested in. I mean, I looked at the manuscript the other day because I was kind of from the start reading it. I wanted to look at the difference between IPI and adjuvant interferon actually, and it was only in the supplementary because, like you say, we kind of knew about the PD-1 IPI bit of it, and I was just curious actually about how the interferon looked. But anyway, over to you.
Yeah, well, the top line is that this study showed a benefit in recurrence-free survival in adjuvant pembrolizumab versus active control, whichever way you compare it, but we compared it, intention to treat lumped together. And then the study had a unique overall survival reporting. So this is the only adjuvant PD-1 study that has reported overall survival. It was not significant, but this is partly because of the way we specified it. Because we didn't want OS to go on and on and on in a government-funded study that would cost a lot of money for us to just keep following these patients for 7 and 10 and 15 years for OS, and just, we just don't have that kind of funding with the U.S. National Clinical Trials Network. We pre-specified that the overall survival would occur, I think it was 3.5 years after the last patient was randomized. So it's like a fixed kind of time to look at it. And that was going to be final. So that was going to use up all the statistical alpha. Anything we do after that's really just descriptive in nature. It doesn't mean we can't do it. It just, you have to interpret that with caution. And at 3.5 years, we hadn't reached the planned number of events that we thought we were going to have to report median OS. So this is reporting less than the median. Nevertheless, there was no significant overall survival benefit. And that's, of course, in contrast to what we saw in EORTC 18071, but that's a different study. That's a placebo-controlled study. That study was done at a time when you couldn't salvage, we weren't salvaging as many patients with adjuvant PD-1, whereas here, the control arm invariably is getting salvaged with adjuvant PD-1, so on and so on.
Yeah, all understood. So I guess that study really answered the question pretty definitively about the role of adjuvant anti-PD-1 in comparison with either IPI or interferon, although, of course, Checkmate 238 had already reported already. I'm just curious because it felt at the time, it's a few years ago now, that even after IPI 10 milligrams per kilogram adjuvant had got an FDA approval, it never got approved, I don't think, really anywhere else in the world. Although I used to talk to patients about it sometimes, you'd have patients coming in who were very well read indeed. And so then I give them the whole kind of story about it. But my question is going to be, how much use of IPI 10 was there in sort of routine practice? I mean, were you trying to talk the patients into it or trying to talk them out of it, as it were?
In that moment that we had it approved, unopposed, that's a good question. I think we were transitioning very toxic regimens. We were in transition from toxic interferon, where patients walked around 365 days a year feeling as if they had the flu, to a regimen that wasn't so overtly toxic day to day, but had some lurking, very serious toxicities that, if they emerged, could be long-term, could be lifelong, could be serious, require hospitalization. So we were, in a way, trading one toxic regimen for another, but just from explicit in-your-face toxicity to more illicit, if you will. And so it wasn't as much that we had to talk patients into it, that dose of it. You couldn't give a 3 milligram dose because we didn't have an approval for that. And, American insurance companies can be very devious. You alter from the FDA approved label, you might not get paid for it. So, but what commonly happened, and you saw it in the EORTC 18071 study as well, is that patients would get that main induction dose, but almost no maintenance. So the amount of dose density that patients actually got was, 50% or less.
Yeah, no, I mean, I'm quite strict about IPI dose, actually. And I mean, again, we used to discuss this in the absence of an approval. And I think we probably treated a small number of patients at the time, but we treated them with IP10, and there may have even been people who are paying out of pocket, right? So if you do the maths on that, it's absolutely not a small amount of money. Although, as you say, a lot of patients will have stopped early. But
Did you say maths, plural with an S, maths?
Yeah, that's how we say it. Yeah. Oh, maybe
Singular.
We can have that as a math or maths. Yeah, no, I know that. But no, we say maths. Do the maths. Anyway, yeah. So I mean, maybe now isn't the time to talk a load about IPI dose, but at the end of the day, the positive trial, the ORTC trial, used IPI10.
Yeah.
And we know, or maybe we'll talk a bit about it now, we know very clearly, at least in metastatic disease, that there is a dose response for IPI. The Paolo Ascietto trial, the 3 versus 10 trial, actually there was an improvement, I think, in pretty much every metric for IPI10 over IPI3. So we know that dose is important, and we know that higher dose causes more tox. So whenever people talk about sort of, let's call them alternative IPI dosing regimens, I'm always just a little bit cautious and say, what is the evidence in that situation? So maybe this is a good time, though, to talk about anti-PD-1 adjuvant treatment, just as a kind of backbone in a sense. So, we can see that it beats the established standards of care. We can see that in general, for most patients, it will not be as toxic as adjuvant interferon or IP10. But what do you think? I think you used the word illicit. What do you think about the illicit side effects of anti-PD-1, particularly in the adjuvant setting? I think in metastatic disease, it's a different benefit-risk discussion. But this is people, depending on the risk groups that you treat in the adjuvant setting, who might be cured anyway. They might be young, they might not need the treatment, and then they get an irreversible side effect or something like that. How do you talk to patients about that?
That's hard. I would love to hear how you talk to patients, because I'm looking for ways to refine my counseling. I mean, I think we talk about the potential of already being surgically cured and the potential of, long-term irreversible or side effects that might disrupt your life, just even having to get hospitalized or come frequently to manage it. So then there's we often think of risk-benefit ratio. This is a kind of a benefit toxicity ratio. It's a similar sort of discussion, but number needed to treat, number needed to harm sometimes is one way to think about it. Though I think it's hard for patients to think of number needed to treat. We treat 10 patients for one patient to get a benefit with adjuvant IPI or interferon, for example, this 10% absolute benefit. I think it's hard for patients to frame that, because are we expecting them to believe they're the one person or the 10 people? I just think it's a hard discussion. How do you frame it with patients?
Well, I mean, I don't find any of that stuff helpful, let me tell you. People do talks on it a lot, number needed to treat. I mean, this is a conversation, obviously, I've had with probably hundreds of patients now over the years. Most patients want to know about them. They want to know what's and some of the times that number needed to treat stuff is framed financially, which frankly I find very difficult, because if you've got a reimbursed treatment, the patients do not need to hear about that. Actually.
Yeah.
What they need to know is, what's the risk of it coming back? Sure, all the stuff about you might be cured already, etc., etc. How does this treatment change that risk, and what are the side effects of the treatment, including irreversible and actually including risk of dying as a consequence of side effects? And so that's how I sort of go about it. And I mean, you and I have probably talked about this before. I think risk is often not well understood by people, actually. The perception of risk by different people varies a lot. You can't assume anything about how someone might perceive risk to themselves. And you said it another time, some people would just say, I want absolutely everything, please. And other people might take a somewhat more nuanced view of it. So I think it's complex. And
can I tell you sorry to interrupt you. Yeah. Can I tell you an analogy I've sort of been running around in my head, which I don't know if this is really going to be great, but I feel like it just shows you how complex the conversation is. But in the US, we have the Tesla automated car. Actually, I'm sure you guys have it globally. But these cars now have self-driving features. But the self-driving feature has gotten in a lot of hot water lately, and maybe this podcast will show its age over the years, because lately, at least in 2024, the concern is that there are accidents by this self-driving and people are using it inappropriately. Basically, self-driving isn't supposed to be so you can be texting on your phone and talking and distracted. And anyway, so it's a little bit like asking a patient, would you like to have the self-driving feature on your Tesla? It might prevent an accident, right? I mean, that's the idea of the self-driving. It's like doing everything you can to add a safety feature to your car. So do you want to do everything you can? Having said that, we don't know everything we need to know about self-driving. So there are times it can go woefully wrong, right? And if it goes woefully wrong, will you have buyer's remorse? I put this added feature on, maybe I didn't need it. I wasn't going to get into an accident anyway. So this has sort of been running around in my head. I think if you pose that same car analogy to a patient, to a consumer, they're also confused about their choice. Well, I don't know. Do I want it? And then if it gets in an accident, am I going to have remorse? I mean, how do you answer that question, right? So this is sort of this is just to make it more relatable to a patient that this is essentially what we're talking about. You could get this feature. You could take this adjuvant therapy. You may not need it. You may never have another melanoma event in your life. And if you take it, there may be consequences that we cannot yet predict in the treatment alone. So
yeah, and some of that comes back to long-term side effects, which I'm sure we'll talk about another time. But I mean, maybe just quickly as a concluding type of comment about how I do this in clinic, again, depending on the patient and so on and so forth. I say there's three scenarios with adjuvant treatment. One is that you're destined never to relapse and you don't need any more treatment. Another one is you're destined to relapse. We give you the treatment, you relapse anyway. But actually, the sweet spot is the one in the middle where you're destined to relapse and the adjuvant treatment stops that happening. So I think that conveys quite a lot of how we think about it, at least as oncologists, I think. And people sort of find that easy to understand. And then the next bit's obviously going to about risk and benefit and so on and so forth. Okay, so yeah, go on.
I like that. I like that analogy. I hope people don't think it's a third risk, because it's certainly not. But I bet there's some probably nice way to convey that illustratively to tell people. The one thing I will say about this risk, and maybe this is intriguing for you, we have a few grants surrounding the SWOG S1404 study to look at toxicity, so biomarkers for toxicity. And this is really an opportunity to capture it. You have an adjuvant study with one of our most toxic treatments, IPI 10 milligrams, and interferon. And you have anti-PD-1 therapy, so one of our most commonly used treatments. So everybody's essentially on active therapy. We're looking at TCR signaling, or sequencing, TCR sequencing of one of the variable beta chains. And, there may be some groupings that these patients group into several haplotypes, and there may be haplotypes that actually are protected from toxicity, which, because, that's essentially what we're talking about, right? Is like, we would love to be able to give you treatment and tell you you're not going to have toxicity, but none of us can predict that. Now, if we could have a biomarker that says you are in a haplotype that looks protected from toxicity, it makes a choice for adjuvant therapy far easier. Doesn't tell you if it's going to be beneficial, preventing relapse. It doesn't tell you about efficacy, but it tells you about toxicity. Similarly, if we have a haplotype that tells you this is a group of patients who get high risk, high grade toxicity to anti-CTLA-4 and or anti-PD-1 therapy, it may it may color that discussion of adjuvant therapy now versus later, anti-PD-1 therapy later, particularly if we see some of these crossover studies have benefit with salvage PD-1. So that's the only thing.
No, I mean, that's a subject close to my heart as well, the prediction of side effects. And I think in the adjuvant setting, not just in melanoma, that would be extremely helpful in terms of benefit risk. I mean, of course, we do have some predictors, history of autoimmune disease. We see that in clinic the whole time, and someone coming on, I'd really like to have adjuvant treatment. I'm going, well, hang on a sec. And there are some HLA predictors, for example, of diabetes. But I suspect the thing with the prediction of toxicity is complex and heterogeneous and dynamic on the different organ systems. So maybe towards the end of our working lifetimes, perhaps there will be a full panel, if you like, of things that you can tick off. But I think it's going to be honestly one thing at a time, actually,
Yeah.
and sort of working out how different things work. Actually, I'm going to say one more thing. Sorry to bang on, which is about the sort of the patient. You reminded me, really, the patient perception of risk and the patient perception of benefit. I think one of our collective problems as physicians, if you like, in the wider community is we all have views on benefit and risk, and we talk to our patients about what those are. But I haven't really seen any great data, honestly, about how patients, and I mean a large group of patients, are really trading off these whole benefit risk kinds of things in their minds. I think that's a gap, and actually, prime for getting some data in that space.
Yeah.
So anyway, we should wrap up though to say that we've talked about the SWOG 1404 adjuvant study, and you educated me about the naming nomenclature, so I never knew that before, so that's great. Biggest adjuvant study done in melanoma, so congratulations for that. RFS benefit for pembro versus control, so thank you very much.
Thanks, James.
Hi, everyone. A quick fact check for the SWOG S1404 episode. We were talking about the approval of ipilimumab in the adjuvant setting. That's one of the control arms that we had in the SWOG study. And I was just double checking when it got approved in the US. It was approved in 2015 by the FDA. And then James said something that maybe it didn't have approval in other countries. I think he's right. I double checked the EPAR for EMA. I couldn't find that it had an indication there. Nothing in the UK, nothing in Australia. So maybe adjuvant ipilimumab might be holding the only approval in the US, but it's, not a contemporary adjuvant option. So maybe it doesn't make much difference. And then just relevant, because we talked about Checkmate 238 and how that sort of beat the SWOG study to the punch. Of course, there was also Keynote 054 that was published, but just for comparison's sake, Checkmate 238, Nivo versus Ipi, SWOG S1404 was essentially Pembro versus Ipi, majority Ipi. And the SWOG study, I talked about the nomenclature, that it's called 1404 because it was approved by SWOG Executive Committee in 2014, hence the first two digits S14. But it didn't actually open to enrollment until December 2015. So it basically used up all of 2015 getting all the stakeholders to approve it. So the S1404 study enrolled from December 2015 to October 2017, so almost 2 years, where Checkmate 238, it was only open for 6 months. It was a very rapid industry trial. It was open from March 2015 to November 2015. So it basically enrolled after the SWOG study was conceptualized, but SWOG had not yet enrolled its first patient. And then I made a mistake when I said when S1404 hit its primary endpoint. I said it hit during the pandemic, which was correct, but I got the year wrong. It wasn't March 2020 that it hit its endpoint. It hit it March 2021. And so it was presented at ASCO 2021 and then published in 2022. It's also worth noting, the SWOG study had a pre-specified, we will look at overall survival one time as a final analysis 3.5 years after the last patient's enrolled. So that's what triggered some of that analysis, because OS was a co-primary in 1404. And it's worth noting that Checkmate 238 has also reported OS, but it's not the median OS. They just have reported some landmarks as they've presented updates. I think James knew this because he's senior on many of these publications. The 4-year overall survival was published in the Lancet Oncology for Checkmate 238, and it just noted at 4 years there was not really a difference yet in the overall survival in the two arms of the study. So that's pretty much it. I think there's one other place where I talk about dose density of ipilimumab and how most people, even in the S1404 study, received their IPI in the induction period, but not in the maintenance period. And I called that dose density. In a way, it is dose density because induction period is more of that dense administration. But I think what I was really meaning to say as I listened to it again was dose intensity. So how much of their planned regimen did they receive? And because they mostly just got induction therapy and no maintenance, it was less dose intensity. So I sort of jumbled those two phrases. So okay, well, that's it for the SWOG 1404 study.